Hello, Nav Kavale here, plastic surgeon. Welcome to the Real Clinic podcast, sponsored by 42 South Films. This is where we take a behind-the-scenes look at the surgery industry, get to meet key players in the business, learn about setting up a clinic such as Real, and meet some of the best surgeons around. Welcome to another episode of the Real Clinic podcast. We are here at the Real Clinic in South London, and today I have two guests. I've got Matt James, plastic surgery colleague, a plastic surgeon that I work with both in the NHS and here at the Real Clinic, and I've also got Sanjay Gulati, anaesthetist, who works alongside Matt. They've been a couple working together for 20 odd years, both in the NHS and in the private sector. They've been pushing things actually quite a lot over the last few years in terms of day surgery, anaesthesia, and doing bigger and bigger operations, honing the specifics of anaesthesia that I think you guys will like. I think pay attention to that because it's all changed and has become a lot more sophisticated but simple, as it were. Allowing us to do more day case surgery in places like this. But anyway, welcome to the Real Clinic podcast, and I'm hoping that we can talk about, what you do individually a little bit, but actually I'm hoping we'll get on to talking about what you two do together, in particular here at the Real Clinic, in terms of your day case, general anaesthesia caseload, and some of the stuff that you've been talking about, Sanjay, when you were at BARPS recently. Anyway, before we get on to that, if it's all right, I'll just kind of do a little bit in the way of intros, if I could. So Matt, tell us who you are, what do you do, where'd you come from?
Thanks for the opportunity, Nav, for allowing me to chat with my left-hand man. It's normally my right-hand man, but he's on my left today. So, I've been a plastic surgeon. I've worked alongside you for a number of years. Since you were at King's, I work at St Thomas's. We've been working together there for about 20 years now, almost. During that time, we've worked closely together for those 20 years, maybe a brief separation during COVID. But essentially, I think what we've managed to develop is a harmonious relationship, yeah? And without wanting to sound too cheesy,
COVID can be tough on couples.
It's very, very important to have a harmonious relationship with somebody you work closely with.
Yeah,
because
absolutely.
Then you can do the right thing by the patient. You can actually get a good anaesthetic, do a safe operation, have the blood pressure controlled during the operation mostly, and deliver what we think is a really good service to the patients.
And what about you? How did you end up at St Thomas's? What's your story? How did you grow up?
So my background was I don't really want to talk about Quincy, medical director back in the 70s, being my main inspiration as a pathologist, but essentially at medical school I was really into medicine to start with, but soon realised that actually the technical side of it I found very rewarding and sort of meditative and relaxing. Actually, these sort of intensities of operation can actually allow you to sort of focus and relax in a weird kind of way. And I gravitated towards plastics because you saw what you did. There was a certain sort of art to doing some of it. My background is actually, I'm a reconstructive surgeon in hand surgery. Hand surgery is obviously very, very functional, but lends itself to you become technically gifted in most aspects of surgery, microsurgery, tendon surgery, surgery on bones. So it actually lends itself very well to cosmetic surgery. And that was my kind of other evolving interest, mainly privately alongside the NHS's, that I started doing a lot of cosmetic surgery.
And you trained in Birmingham, is that right?
I trained in Birmingham, yeah.
And did you do all your plastics training there as well?
I wasn't actually exposed to plastic surgery until I came to the Royal Free Hospital in London, so I did all my sort of specialty training in London, and it was only I just tried it as I was actually probably going to be a career urologist, because again it was a very technical specialty. And I had an epiphany one day. I won't sort of go into the details, but wearing Wellington boots with a lap full of urine, and I got some exposure to reconstructive breast surgery at that time, and it literally just blew me away. I just thought, my God, this is fantastic. And that whole kind of reconstructive surgery, like being able to actually reconstruct almost anything with microsurgery, composite tissue transfer, And then I enjoyed the hand side of things. I found the kind of breast reconstruction, it was a bit repetitive. You're doing the same operation every week. You really are just on a production line. Whereas hands, the decision making was always individual. Every time you saw a patient, you might do something slightly different. So it was much more sort of thinking about surgery. But I kind of miss the creative side. Like the aesthetic side is much more creative, much more artistic.
And how did you get into the aesthetic side? Is that just because my impression, it's a bit like my private practice. I was doing trauma surgery in the NHS, which isn't conducive to a parallel private practice. So I ended up defaulting into aesthetics. Is that sort of what happened to you?
I did an aesthetic fellowship, and I just really enjoyed the aesthetic side of it. And I decided that when I became a consultant, I was just going to do general cosmetic surgery. Yeah. And obviously, when you start out, that's quite nerve-wracking because we had a slightly different approach to our training. We didn't get much aesthetic exposure. We got some, but not much. So a lot of it is learning on your feet. You have a mentor, you share ideas with somebody that you trust, you get them to come in and help with cases that are more difficult. And it was also spotting the cases that are more difficult. That's initially, so now I would probably do things that are much more complex, perhaps more technically demanding, perhaps, we are doing some fairly amazing things as day cases here.
We'll come on to that actually, definitely.
But when you start out, you have to just make sure that you can't operate on every patient that comes through your door. We know that anyway, they've got to be good patients. But you also need to step back from those cases that are more difficult, you need to get help with. Or you need to refer them on to somebody. It's so important, I can't emphasize, to anyone that's training, that you have to have a mentor and you have to have a team that you work with when you start out. Otherwise you get very, very isolated. And if you're isolated and challenged, you're going to get really, really stressed.
Yeah.
So,
and we probably can think of colleagues who've kind of got themselves into little spirals and rabbit holes and are just sitting there doing weird
that's what I love about working here is actually we're all friends, but on a professional level, good colleagues, trust each other, share ideas, and sort of push the kind of quality of what we're doing.
Yeah, we'll come on to what you guys do at the clinic in a sec, actually. But sorry, I've been neglecting you, Sanjay.
Sanjay.
Yeah. So Sanjay, same question to you. Tell us about yourself, your background, and how you've ended up here.
Yeah, so I grew up in Glasgow. You won't be too surprised to hear. And I went to medical school in Glasgow as well. And then after, I suppose not really knowing what to do exactly, I wound up in anaesthetics really, slightly by accident, but I enjoyed it. And after a few years, I moved down to London. It was I'd outgrown Glasgow, I suppose, and the breadth of exposure to different specialties, people from diverse backgrounds, a much more vibrant city. So then I settled in London, and almost immediately after taking a job at St Thomas's as a consultant there, I bumped into Matt almost immediately, and we've been working together really for nigh on 20 years now. The aesthetic side of things, I only really got into actually around COVID time. There was a lot of change of working patterns where people had to change lists in hospitals and working days and so on to accommodate for COVID, and we wound up working together, and also with the availability of theatre space changing. By accident almost, we wound up doing a lot more stuff as day case surgery. And what was, I suppose, a refreshing and somewhat surprising to us was actually we could do more and more extensive surgery, and the patients just really, the one thing they all appreciate is being at home on the day of surgery. And I haven't heard a single patient say, I wish I'd stayed a night in hospital rather than be at home. So that's always been very gratifying. And
have you got any kind of background training in day surgery in particular, or blocks, or regional, or what have you got a subspecialty, as it were?
I mean, to be honest, I think we overplay a little bit the subspecialties in anaesthetics. old enough and long enough in the tooth that we all basically did everything, and the subspecialties have kind of happened subsequently. I was, I suppose, a regional anaesthetist. In fact, with Matt, we did a lot of surgery under regional anaesthesia, awake, with arm blocks and so on. We were early adopters of using ultrasound regional anaesthesia at St Thomas's, and we really thought that was great stuff. That we could do quite extensive surgery without people having general anaesthetics. But I suppose subsequently, what's happened is we started to look at a sort of a wider recovery picture on how people get on after the surgery, but not just focusing so much on the first few hours, but focusing on the longer term. And of course, regional anaesthesia is only amenable to certain types of surgery. Mostly regional anaesthesia is a supplement rather than the actual anaesthetic for the surgery. So at Real Clinic, we've really been only using local infiltration and general anaesthetic, and what we've found really is that we can modify the technique to allow patients to mobilise quicker and be discharged quicker, and actually they have a good post-operative journey.
Don't forget the combo Gesic.
Oh yeah, yes.
So we basically moved away from using opiates pretty much at all. Yeah. And then I phone all the patients. Patients will phone me when they get home just to make sure they're okay, and then they phone me the next morning. We're finding that patients are not actually taking any opiates whatsoever. They're given them if they want them, but they're actually not taking opiates.
And this is stuff like tramadol or dihydrocodeine, is it?
Or actually mainly fentanyl intraoperatively. Yeah. So it's absolutely mantra and standard, I would say, that every general anaesthetic uses some opiate, fentanyl or alfentanil, as part of the balanced anaesthetic triad as it's been taught for decades. What I think we've been doing really, and we've noticed this with remifentanil, is that if you give people a lot of opiate intraoperatively, they develop this acute tolerance, which leads to them needing more opiate post-operatively.
So just before we get into the details, explain to me, as if I don't understand it, what do you mean by the opiate part of an anaesthetic? What do you mean by the rest of it? So remifentanil is an opiate.
Remifentanil is an opiate, fentanyl is an opiate, morphine's an opiate. Yeah. Oxycodone's an opiate, which many people...
Heroin's an opiate.
It certainly is. The anaesthetic part is the bit that keeps you asleep. Yeah. The opiate part is the pain relief bit. And then some people also need paralysis, a muscle relaxant. And that's the kind of the classic triad of anaesthesia. Yeah. But, this is really something that's been in the book since the 60s. Yeah. And it hasn't, I don't think the thinking has really progressed that much. And we know, everybody knows about the opiate crisis. And
so what you're doing is no opiate, is that the idea?
So the idea is intraoperatively they get no opiates. Yeah. They do have a small dose of remifentanil, which is very ultra short acting and at low dose, but they don't get any longer term opiates at all. So I haven't used any fentanyl here intraoperatively for more than 12 months. Yeah. We started off a little bit cautiously, give them a little bit at the end, or for the bigger cases we give them a little bit, but actually even for big cases here now, they get no fentanyl at all before waking up.
And I suppose the theory is that your body, in response to trauma, produces its own opiates. Yeah. So by giving opiates, you suppress your body's own natural production of opiates. Yeah. And therefore, if you don't give opiates, the body naturally starts producing its own opiates and continues to produce those natural opiates in the post-op phase. So no constipation, no nausea, people aren't waking up. So the standard thing I used to, when I worked with an anaesthetist, who, loving look, who was a pain specialist, patients used to get a PCA, they would get spinal morphine, and they would wake up and they would be sick. They would be so sick. And if you've done a repair through the midline and you're retching against it, it's a horrible recovery. And then the next morning on the ward round, they've been given opiates all night by the nurses because we think, there must be pain, we must give opiates, yeah? But these patients just the next morning, they're flat, they couldn't move.
Absolutely. They're sort of institutionalised by then, aren't they?
And now, literally they're walking out an hour and a half after the operation, getting in a cab home, meeting somebody at home, going to bed and having a good night's sleep.
So let's talk about what we've done here at the Royal Clinic, I mean, from my point of view, we're TIVA anaesthesia, we're not using any gases. That's been the big game changer as far as I'm concerned, from my point of view as a surgeon. And then on top of that, yes, no morphine post-op is certainly one of the things that I picked up at places like the Cadogan. But you're taking it a step further in that it's not even no morphine, give them fentanyl instead, which is what sometimes happens here. It's like no fentanyl, and yet they still manage to get up and walk out.
I mean, almost the converse. So I suppose what we started with was reducing the amount of opiate, and it almost felt like the less you gave, the better they were post-op. And actually, what I was surprised by was the consistency with when you phone the patients. They almost all say the same thing, and I don't know if they almost always say, "Oh, it's much better than I thought it was going to be," and it's the phrase that I get almost routinely. In case in point, the patient this morning, I mean, she I think about 1 hour post-op looked like she was ready to go home, which is really not our experience of anaesthetics.
And this is a tummy tuck, isn't it? And a relatively older patient as well. Yeah.
So I think my personal feeling, and I've looked at some of my own data, is that all the nausea and things that we've been blaming on the gases, actually, I think a large part of that is actually due to the opiates, or the combination of the opiates with the gases. And what I found is actually I'm still using volatile anaesthetic, and of course you don't have gases here, I'm going to use TIVA only. But the nausea rate for the volatile anaesthetic, in my cases only, and so those numbers are quite small, is exactly the same really for me with using TIVA.
Antiemetics?
Routinely give antiemetics here and there, usually 2, but that's standard I think across the board for everybody now. But there was no difference in the rate of. So I think it's the opiates that are causing the problem rather than the gases, or certainly the combination of the opiates with the gases.
And does that mean that your colleagues, your anaesthetic colleagues, think of you as a maverick or heretic, or are you an outlier, or are you? Are they coming around to your way of thinking?
You're an outlier at the moment. But
Slightly.
We're going to do a study that's going to prove that this is the way forward. So that's ongoing at the moment.
That's observational studies. It's not going to prove it's the way forward, but it's at least going to show that our data is showing a good quality of recovery.
I mean, I think there's nothing. Day case surgery is nothing new. It's been going forever in the States. We're actually, I guess, we were lucky enough to come to a place where almost like you don't rely on the bed afterwards. The anaesthetists, basically they're just getting people into a bed and that's it. The job's over. But actually, the job is not over. The job is to make sure that you do the right thing for the patient for the first 24 hours. Make sure they're not in pain when they get home. Make sure that they're not going to suffer a complication at home. It's so easy when you're in a hospital. You think, okay, job done. I've done my bit.
Hand over to the night team.
I think that's actually a really good point. I've never really thought of it like that. But there's no doubt that here, and actually it's translated into other bits of my practice as well now, is that there's really no point in me saying, I've managed to get the patient to recovery. That's really not the job here, is it? I mean, if they don't go home, it's
then you don't go
the job's not done.
If you were now, I don't know if you guys still do hand lists at St Thomas's, for example, upper limb. Are you GAing those patients? You're not bothering with blocks anymore?
So I'm not routinely doing a hand list with Matt, but we've done a few hand cases.
If you were to do,
it's still my preference is. So the problem with doing regional blocks for me is that if you're doing complex upper limb surgery and you have a tourniquet and you have a block in place, the limb will not vasoconstrict for about 24 hours after the operation. So you get this prolonged swelling after a block. So if I was going to have an operation as a day case, I would say general anaesthetic, no opiates. At the site where I make the incision or do the surgery, I put in local anaesthetic with a hefty dose of adrenaline 15 minutes before the tourniquet comes down. And then you get much less swelling, less hematomas. The pain relief's fantastic because you've just targeted exactly where you need it. And again, these patients aren't paracetamol, ibuprofen, none of them are getting opiates afterwards. And we know that 3% of patients that come into hospital and get opiates are given opiates to go home with, they get addicted. So 3% of people that are coming through the system are ending up with opiate addiction. Either we're getting them back into that opiate addiction, or we start a new opiate, we start a new addict. And actually, we've got to stop doing that. You know, it's really important that we get this message out that opiates are, they're
bad.
They're bad.
Yeah.
They're bad.
I mean, I wouldn't go as far as that. I mean, what I would say is that for every intervention and every treatment that we have, we should assess the risks and benefits. So rather than giving opiates as a routine without considering whether they're required or not, I think it's important to evaluate the risks and benefits. Give opiates where you need them, and you know, we use opiates post-op. So some patients in recovery will need some opiates post-op.
But I think that's the important thing, is that we kind of give them the choice. So we give them some and say, you probably won't need them. It's all about how you set it up with patients as well. Just say, look, there's going to be some pain. Obviously, you can't have a major operation without some pain, but the pain will be tolerable. And if you are struggling with it, then take some codeine, take some opiates.
So let's just slight tangent. If we compare ourselves to the US, because the US appears to have a huge opiate problem, and I've treated a few patients from the US, and the attitude towards pain seems very different. But it's certainly not, you will have some pain. It's kind of, I want to have no pain, please, seems to be what I hear from patients from certainly from the USA. Is that a fair assessment, do you think, Sanjay? Am I being a bit too generalised? Because how come the US has such a problem?
I mean, I couldn't comment on American patients versus British patients. I mean, I've done, you know, a smattering of American patients, but only in Britain, and I haven't found them really to have different pain thresholds to anybody else, really. I do think that we focus too heavily, really, on the first few hours post-op. So all the regional anaesthesia, all the nerve blocks, all that focuses about how you wake up. But actually, most patients, when you ask them some time later, so some weeks or days later, the first few hours aren't the bit that's important to them. You know, when it's in the context of their whole recovery, the first few hours is just a blur, really. And actually, they've also had all the drugs at that time, so it really is just a blur. And the overall recovery is the important bit. So I think we just need to broaden our horizon a little bit and look at the recovery over.
Well, the thing is, the anaesthetists they literally look after that patient for 4 hours afterwards, and then it's the surgeon that then sees how they're doing over the next couple of weeks. And actually, we put the responsibility of the analgesia onto the surgeon, but they're not the ones kind of monitoring it afterwards. Onto the anaesthetist, but it's the surgeon that kind of knows what's happening for those 2 weeks or 6 weeks even. You know, you'll never see the patient again. So actually, we've got a bit more we've got these data points, and actually I found that they're not in pain. They're not. So you can say to the American patients, the pain is not that bad. Your body produces its own opiates, and actually that's how you sell it, really. You're actually suppressing your natural endorphin production by taking opiates.
That's what I've certainly found is, it does take a lot more.
But trying to get that across to people, because we've been hard sold. This industry's been, makes a lot of money, and it's in the system, and it's hard.
The whole you will be in no pain thing has been, I think, over-egged.
Yeah, I mean, it's not possible to have an operation and be in no pain. It's just not possible. The pain is coming, whether it comes after your block wears off, or whether it comes when you wake up, or whether it comes some weeks later. You will always have some pain after surgery. It's just not possible to do with that. Can I just say one thing quickly? I think this is where the relationship side of things is important. The model for anaesthetist surgeon working together in a lot of places is not consistent. So that you're working with somebody different or unpredictably. In different days and different weeks, so that feedback doesn't exist. And I have been working on that for a hell of a long time now. So when the patients don't do well, we have a conversation, and we can adjust what we're doing based on that feedback. Whereas if I don't actually know what's happening to the patients, if I only see them in recovery and they're good in recovery, I've got no reason to think.
Yeah, I think you're absolutely right. Actually, yeah. I mean, I work with a consistent two anaesthetists I work with, and that's been going on for 15 years now, and it's again, as you guys have been saying, I think it's so important.
You phoning them up the next day as well, the patients. I think that.
Yeah. I mean,
Only because you didn't believe me when I was saying there was no painkillers required.
Actually, that's something I've often wondered is, as surgeons, and this is one of the things I guess I'd criticise anaesthetists for, is that you guys don't do pre-op clinics, post-op clinics. Is that something that perhaps we should start doing?
I think it just depends on the model in which we're working. I mean, certainly now the public sector model, which I suppose is reflected back into the private sector, is that the outside of the operating theatre, that service is all centralised. So pre-operative assessment is done by a group of people who do pre-assessment. It's quite difficult, particularly again if you don't have consistent lists and flexible working patterns, to know who is going to be doing which patient when they're going to be scheduled and so on. So it really is quite a difficult logistical exercise to get the same person to monitor the patient.
But in your private practice, because you two are a twosome,
we underestimate how much the patient actually is worried about the anaesthetic. And I've had lots of patients say, "Oh, who's the anaesthetist? Who's the anaesthetist?" It is an important factor to them, and often, like you were saying, if you don't have an allocated anaesthetist that you see all the time, you might get somebody, through a bank system, or certainly in the private sector, you may have an anaesthetist you've never seen before, and the patient then is, how do you reassure the patient that that's the right anaesthetist if you don't know the anaesthetist, So, if I get a patient that's worried, I can just, I can say we've had a long-term working relationship, set their mind at rest. And I think we do underestimate that. I think we should be...
If you've got somebody who's worried, you'll just say to me, can you talk to this
person?
I'll give them a call. So I think that is...
I think that's so useful, actually. I do that quite often. I know the two guys that I work with, been working with them for years in the NHS. They are, experienced, safe, nice. And I try and answer the questions about anaesthesia. The common one is, what's the chance I won't wake up? That's one of the questions I get quite often. I always say somewhere between 1 in 500,000 to 1 in 1,000,000. I don't know if that's right.
I'm not sure it's right though.
But I think, being able to have a consistent person. I do wonder whether it would be a good idea for you guys to see the patients in the same way that I see them pre-op and I see them post-op at least once. For me, it's the high-risk patients are the ones that you've got to know about. And we do occasionally run things by each other when there is a higher risk sort of patient. And I think, coming back to this relationship, like if you have an anaesthetist, and it reminds me of a case I did a couple of weeks ago with a different anaesthetist, that the blood pressure's got to stay below systolic 100 if we can during the difficult part of the operation, so that we don't get too much bleeding. And then after when it comes up after, it doesn't really matter. But a lot of anaesthetists will not be there. They don't know how to kind of drive along with you, as it were.
Exactly. Yeah. And again, when it comes to waking the patients up, there's a skill to making sure that someone wakes up on time, not too sedated, so that you can have them out of the hospital in 2 or 3 hours. And I think that's a skill that comes with pattern recognition and not using opiates. It comes with time, and actually you find a lot of the say more mature, more wiser or older anaesthetists are fantastic at that. I say it's like surfing. You got to pick up the wave, and when the wave is ready to break, that's when you turn off the anaesthetic. And actually, so many anaesthetists, you'll find that the patient's still asleep an hour, still in recovery. They still haven't recovered from the operation, and I don't think you can get that unless you've got a close, harmonious working relationship.
Exactly. And on the flip side, if I work with somebody I don't know, it's much more difficult for me to know when the wave's coming, right?
It ends up being a lot more a frowny day, as I call it. It's
almost subconsciously, just from some cues. And I was doing a complex hip replacement yesterday, and I was talking to somebody behind the drapes, so I couldn't see anything. And I said to her, "Oh, we've got about 15 minutes to go," and I can't even remember what it was that I heard or whatever it was that what the cue was. But actually, I've done so many of those hip replacements with the chap I work with that I know the timings just actually as second nature, and it's much more straightforward and
I think there's a lot of unseen that we do that we don't realise that we're doing unseen. A lot of
absolutely. So let's move on to what you guys do here at the Royal Clinic. Okay, so I know you guys have been pushing things over the last 12 months, and it's been working really well. And we heard about some of that at BARPS recently. So let me just start off with you, Matt, and then hopefully you can.
So my practice
so
here.
What have you been doing here, and how have you seen it grow?
After COVID, there was a lot of reshuffling of lists around London. I actually came here because it was a day case, and we'd been working at another hospital that was predominantly day case. And obviously, starting in a new place, it's quite nerve-wracking. So initially, the case selection was simple cases, get to know the hospital. But as we've been working here, we're doing some big cases now as day cases, like breast reduction, abdominoplasty in the same patient. Again, I like most operations to be under 4 hours, because I think if you're going above that, complications start to go up with wound infections and things like that. So any surgery that we can do in under 4 hours, and we often use our surgical assistants, and we've got BARPS fellows here that help speed up the operation. And so what we found is actually we can do brachioplasty, thigh reductions in the same sitting, generally 2 big operations at the same time. We don't use drains, so there's no drains, everything's quilted down. And I'd say since I've worked here, touch wood, no hematomas, very, very few problems. Yeah. Probably more problems when I have that hospital facility, and I can't really work. I don't know why it is. Maybe we're so worried about patients going home still that maybe we're more careful. I don't know. I can't explain it.
No, I think it is, and it's almost the sort of thing that people don't believe, because you kind of say, look, no, honestly, they do really well.
We used to put drains in for 3 days. I mean, it's insane.
Yeah. So and give us an extreme example of a case that you've done here.
So we did bilateral breast reduction, fleur-de-lis abdominoplasty. We might have done a brow lift and some upper lids as well. So again,
in one patient.
Okay,
yeah. And that did fine.
I think that might have been the.
She was about 6 hours, wasn't she?
Yeah.
She did take time.
Okay. So if you think of that patient and having pushed up to doing that level of patient, how's that evolved and how's that going?
She was no different. She was great post-op. She went home about 4 hours post-op. Yeah. So we actually looked at the data for the combination cases and their home time. So these are the biggest cases that we do, was 4 to 5 hours post-theatre. So that's including recovery. 20% of those patients had no fentanyl or tramadol at all before they went home, so they literally had no opiates at all during their hospital stay. And when we phoned them the next day, the patients were very good. So really, it didn't seem to.
Doesn't seem to be how long the patient is asleep, so much as how much cumulative kind of opiate that you've given during the operation.
Yeah. So what are the factors? So cumulative opiates. So what would stop a case from being done here in your mind now? What's the limit?
I think the one downside, or one of the downsides of not using opiates, is that you have to compensate by using a bit more propofol, and the propofol accumulates over time. So I think that's where there's a slight disadvantage over the gases. I think they accumulate to a lesser degree in the sort of fat reserves. So I think once you get to a certain point, you've just had so much propofol that actually to be lucid and have recovered well enough to actually be on your own 2 feet, walk out the door, get in a car, all those things.
So that's long operation.
Yeah, so I think that's just...
Anything else? BMI limits, blood loss limits, heat loss? What are the sort of, as a surgeon, what should I not be listing?
Again, I don't think there's any hard and fast kind of. So we would do somewhere with a BMI of 35 if it was breast reduction, take weight off the chest, things like that. I obviously normally ASA 1 and 2.
Although I don't think that's a hard and fast rule. I think there's basically a balance, isn't there? So if you've got a patient who's perfectly fit and well, with no comorbidities, and no medications and so on, then actually you can really do quite a lot to them and expect them to bounce back and be able to get out the door. If you've got a patient who's not in such good shape, they're ASA 3, they've got diabetes,
you're anticipating blood loss because they're cardiac,
then keep the operation small. So I think it's basically a balance in this.
My limit tends to be, there's no operation that I'm not happy doing as a day case, but there appear to be patients on which I shouldn't be doing it.
Yeah,
difficult patients rather than difficult operations.
These patients are only different when they wake up. They're still, without the opiates, they're still it's just that kind of, you want maybe some monitoring for a few hours afterwards. If they're you've got to keep an eye on blood sugars, blood pressure if it's up and down. There are some patients where you just need that monitoring for 24 hours. I still do it drainless. I still wouldn't put a drain in, but...
And actually there are definitely patients where we have taken them to a facility with overnight facilities. And at the end of it you think, oh, we didn't really have to do that. She was absolutely fine. But I think if you're working in a place where you don't have an overnight option, then you just have to be sensible. You can be realistic, you can be ambitious, but I think you don't want to put yourself in a position where you're routinely failing to discharge, because that's not good for anybody. So
interestingly, when the patients have come into hospital facility overnight and I speak to them, see them the next morning, they've almost routinely been given opiates by the nurses.
I think it's dogma, isn't it?
It's dogma.
It's dogma, yeah.
We can't break that down.
Because I will do a tummy tuck here at the Royal Clinic and the patient goes home. A few hours later, it might be a little bit longer than with you guys because of the slight difference in anaesthesia or post-op opiates or whatever. But I'll do the same operation on a Friday in the NHS, and that patient more often than not is still there on Monday or Tuesday. I'm about to go and see a patient that I did on Friday that I bet you is still there.
It's a very true phrase, isn't it, that if all you have is a hammer, then everything looks like a nail, right?
Yeah.
And I think it's been such standard practice for decades that patients in hospital have surgery, they have pain, and they have reasonably regular opiates, and it's so routine and normalised and they get on every round.
Even in the day surgery unit in the NHS, where the place is designed for patients to go home the same day, it's interesting if they happen to have booked a bed, that appears to be the sudden death move. If you book a bed, then they're going to have to use it.
Now there's a lot of talk about preemptive pain relief. So if you have a nerve block, people will say to you, make sure you have this before the block wears off. And the expectation of pain coming. So I think there's quite a lot of preemptive pain relief going on as well. So even if you don't have to, you have it just.
We have to tell patients, I guess, that there's going to be some. You stub your toe, there's going to be some pain, and it's not going to go on for too long. You'll be fine with it. And actually, I think as doctors, we've kind of lost that message. We don't counsel patients appropriately. Pain is an entirely normal thing to feel after trauma.
Yeah. And it's coping with the pain rather than having none is
I think it's being able to rationalise that pain is a normal part of the process of healing. And actually, I move that way, it's a little bit sore. That's telling you not to do too much movement in that healing phase. It's normal to have pain.
Yeah, when I get my patients to stretch out and my tummy
and the normal patient experience should be, you go home, you rest up, you recover, your mobility comes back over a couple of weeks. You don't battle with constipation during that time because you've been taking too much opiate, which also affects your mobility. You're not eating well because you feel nauseous the whole time. So really for us, it's like you go home, you have a couple of weeks resting up, the pain's not too bad, there's no constipation, you don't see us in clinic for 2 weeks. In clinic, we just take the dressings off, I do the same as you, we just micropore tape, there's no stitches to come out, and well, you wipe the wound and reapply the tape. I mean, it couldn't be easier, really, the whole process. And I think what I've found is that most of my patients are completely bemused about the whole post-operative experience, and they will almost routinely say, "I can't believe it was so simple. You know, it's so much simpler than we're kind of, or that they realise
that it had been built up to be
such a big thing." Yeah,
exactly.
So of course, all patients are different. Patients with chronic pain, for example, I think this is quite hard to achieve on. So I wouldn't want to have a day case only facility option for a patient having reasonably major surgery who does have pain issues in the past. It's just, you know, too high a risk to take. So again, I think you've got to be sensible about patient selection. But patients also who are anxious, we do plenty of patients who have been very anxious about the anaesthetic or pain in particular after the anaesthetic, and I must say they've been very good. You know, we've really had good experience with those ones, and there's a lot of people who are, of course, you know, tainted by bad experiences, and I must say they're mostly reassured, and I think the environment here is very conducive to that. You know, it's a very calm, relaxing place. You know, it's an abundance of light, and you know, people.
You've done a good job.
Feel that, you know, they're just coming here to have a treatment. You know, it doesn't feel like you're going into a big scary hospital to have something, you know, very bad done. It just feels like you're coming in to have a treatment.
Something normal, yeah. I think that's the other thing, is also that we are now starting to treat aesthetic surgery, perhaps a bit too much in certain parts of the world, as being a very normal, routine, everyday thing to do. So let's we'll start winding up, if that's all right. We've been going for a while, actually, longer than I thought. The future. So what are you going to push it to then? What's the next level to take it to? Day case free flap surgery? Day case open heart surgery?
I mean, so for me, I think we've got to the level where we want to be. I'm doing complex enough surgery as a day case. I think for us, we want to try and get that message out that opiates are delaying recovery to some extent. And through the study that we're doing, we're going to actually, you know, I think just try and push the agenda that opiates are not good in, you know, I think if I've done that, I've done something good, yeah.
I'd agree. I mean, I don't think it's a contest on who can do the biggest operation as a day case. I think, you know, you have to be sensible. But I do think, again, that even for major surgeries and non-day case surgery, it is important to consider reducing the amount of opiates we're using to enhance people's recovery, whether they're being sent home on the same day or later. So
what's the take-home messages? If we're going to give a list of things, what do you want to say?
The future is doing more and more surgery under local anaesthetic. I mean, specifically in hand surgery, I mean, we do most of the WALANT surgery, wide awake, local anaesthetic, no tumescence. And that allows us to see the hand move because the patient can move it while you're doing functional operations. I think the opiate-free day case anaesthesia, I mean, there's very little surgery that can't be done as a day case. And what's really blown me away is that we don't need to give those opiates afterwards. It's made a huge difference to me. And I look forward to just carrying on doing these big operations and getting people out the door a few hours afterwards. I can keep a better eye on them now by mobile phone. Everyone's in mobile phone contact. And I think the patients like that. They feel like they're being looked after afterwards. And they are. They're being looked after well.
And from your point of view, Sanjay?
I'm looking forward to doing the study that we've organised.
Give us a quick summary of that.
So the study is really just an observational cohort of patients who will have take-case surgery without opiates intraoperatively, and then we're just going to follow them up very closely with app-based patient-reported outcomes. So we'll get very good granular data on exactly how they are recovering post-op. Which I think will give us a powerful message to convey.
Yeah, and we're using combogesics, which is IV paracetamol and IV ibuprofen.
It's the combo, isn't it? It's literally, yeah, it's in the same vial, yeah. And this is due to start soon, is it?
Yeah, so we've got ethics approval. We're just finalising.
Okay. How long is it going to run? When are we going to hear about it?
6 months.
Okay, so by the end of 2026, we'll have some data.
We'll feed back to you.
So Sanjay, how about you? What are your take-home headlines that you'd like to impart to your colleagues, to my surgical colleagues, our surgical colleagues, and those future couples like you guys that are up and coming working together?
I would say that more now than before. I think a good working relationship with the surgeon you work with is really very important, because it's the best way of ensuring feedback. And I think doing day case surgery has really changed my focus from that very early post-operative period to the longer recovery. And I think we're more aligned now in that you know, we're both vested in the kind of the longer term recovery of the patient. And I'd also say that working here has actually been a real pleasure. It's a great environment. All the colleagues are very supportive, and it's a great place to innovate.
I think a harmonious environment, as we started, is the key to having a good patient experience and a good outcome.
Yeah. No. So thank you. I think we've been going for the best part of an hour, I think. So thank you both for coming. And I quite like the fact that we focused on, I think, the surgeon anaesthetist relationship in terms of
real stuff.
Yeah.
For the real clinic.
Yeah, absolutely. We kept it real. So thank you both for coming, and see you soon.
Thank you.
Thanks, Nav.
Thanks
Cheers.
for having us.